printouts and the various graphs which we get usually in our ophthalmological practices. We'll be discussing about the nuance of these graphs, how to decipher them, how to basically understand the findings, and how to correlate those findings with our clinical findings to finally reach out the diagnosis. My co-instructors are Dr. Rakhi Kushumes, Dr. Mamta Singh, Dr. Nilesh Mohan, Dr. Subhas Prasad, Dr. Rashmi Kumari, and Dr. I'll be dealing on mastering the Humphrey field printout. So let me first invite the first speaker of this IC map and graph, that is Dr. Rakhi Kushumes. She is additional professor at Regional Institute of Ophthalmology, Patna. She passed out from Meerut and then did her senior residency. She is a fantastic corneal surgeon and a very dedicated worker and working towards the cause of cornea. So she'll be talking on deciphering the specular microscopy with clinical examples. Welcome, Dr. Rakhi.
First of all, I would like to thank Vibhuti sir and AIOS Scientific Committee for giving me this opportunity. So I'll be highlighting some important point, how to interpret specular microscopy and what are its clinical implications. So I have no financial interest. Specular microscopy is a very practical tool, not only for the corneal surgeon, but for all ophthalmic surgeon in identifying the subtle changes as well as the macroscopic endothelial changes prior to any kind of ocular surgeries. So we routinely do this test on all the patients, nearly all the patient in OPDs, but the problem is we cannot keep the record, we cannot document these findings for the monitoring of patients. So specular microscopy is a non-invasive modality which can document the healthy as well as diseased endothelium photographically. And with this test, you can monitor the patients. What types do we have? We have clinical setting specular microscope as well as eye-bank settings. In clinical settings, we have two type of specular microscopes, non-contact and contact. In non-contact specular microscopy, these things are very quick. We can get the quick results. Anybody can do for it. But it gives less magnification and resolution in comparison to the contact one. Because the contact specular microscopes use, they applanate a larger surface of cornea to get the good results. So irrespective of the type of specular microscope, the optical principle will be same, that is specular reflection. So as we know that if the light falls on any surface, it may get transmitted or part of it light absorbed and part of it get reflected. So what the specular microscopy does, it actually catches the light which is coming from the endothelial and aqueous interface and then gives the picture of endothelial image. So what are the methods of analysis? There is automated method of analysis which is present in non-contact specular microscope, and here machine itself trace the cell borders and take it for analysis. Another method is manual, where we put a frame on our endothelial image and we count the cells lying under that frame. So in this method, we can miss out few cells which are present on the borders. So there is another method to overcome this problem, that is variable framing, where the complete cells are, we get a boundary around the complete cells and then those cells will be taken for the analysis. So there are other methods also, like corner analysis, where the corners are identified and then counted. Center analysis, where we put dots over the complete and healthy cells and then take for analysis. Center flex method, where these two methods are combined and automated, as I said, in present in non-contact one. So depending upon these things, important is that endothelial image must be good before analyzing the parameters. So come to the image analysis. There are various machines present in the market, Topcon, Tomy. I have no financial interest. Printout will look different, but all machines will give same parameters and they all are equally important. So this is a printout of a Topcon machine. Here we have many datas in one printout. One is the patient detail, name of a patient's age, the date of capture, and then second is the endothelial image, where first one is the raw picture and second one is the traced image. It is done by the machine. And third one is the what type of method of analysis or capture of image has been used. And then this part is very important. Here all quantitative parameters are given in this column, and then the colored image which gives the cell size and cell area present in the endothelium. So in analysis, we can do it by qualitative assessment or we can do quantitative assessment. Quantitative is important. And I'll take first quantitative analysis. So in this chart, first is number that is written 190. First year resident can say that this is a cell density, but it is not. Number is actually these 190 cells, actually they have been taken for analysis of whole parameters. So second one is the cell density. Here it is 2836, means the number of cells per millimeter square. AVG means this is the average cell area of cells. Standard deviation, is actually it shows the deviation from the mean cell area. So if it is large, that means there are more variety of cells present. There are large variation in the cell area. Then the CV, this is a coefficient of variation which depends upon the standard deviation. Max and minimum means what is the maximum area of the cells and what is the minimum area of cells. So cell density always take it in terms of the age. Like 89-year-old patient cannot have 3500 or plus endothelial cells. So if he has 2000 endothelial cells, that is completely okay. Second is important thing is polymorphism. Here we see this cell area of the cells. If cell area has a lot of variation from the mean cell area, that means the standard deviation is very high, and in that case CV would be rising. And if CV is more than 40 or even 30, then you can consider that there is something happening inside the endothelium and you should check it with the clinical examination. Similarly, pleomorphism, where the variety of cell sizes are present. Majority cells are hexagonal, and we expect there should be 60% hexagonality must be there to be endothelial cells very healthy. So it's an indicator of wound healing. Now, second is the qualitative analysis, where we see the cell borders, cell shape, intraendothelial structures, interendothelial structures, and we can also see some bright and dark structure that could be normal and that could be abnormal. So bright structure in normal endothelial cells could be cell nucleus, and the dark structures could be endothelial cilia or vacuoles. In abnormal endothelial cells, we can find pigment or KPs as a bright structures and guttae as a dark structures. So these are the pictures, and we just have a look of these endothelial cells qualitatively, and should be correlated with the slit lamp photographs. So this is a case of 20-year-old young male. And if you look at the data, the endothelial picture is totally normal. And if you see the parameters, the corneal thickness is 539, counts 3062, CV is absolutely normal 30, hexagonality is 57. The same patient, other eye, has been operated for healed keratitis. He had PK done 3 years ago and one episode of graft rejection. So here you can see the size of cell is very large. Still the CCT is good, 469. Cell density is just 649, but he's maintaining 6.9 vision with this, because hexagonality is 50% and CV is 27. So this is another, this is same case, comparison of right and left. You can see the after penetrating keratoplasty, look at the size of cells in grafted cornea in comparison to the normal cornea. So this is one of the very common indication for specular microscopy, that is Fuchs dystrophy, and here we see many dropout areas in printouts. Still, the parameters are within normal limits, and patient has no complaints. Like CV is 34 and hexagonality is 61, counts at 2898. But as these descemet excrescence, they grow with the time, they actually cause damage to the overlying endothelial cells as well as the adjoining cells. And at this time, patient may start develop some corneal complaints. So this specular microscopy actually helps in imaging the peripheral corneal endothelial health in Fuchs dystrophy. And it is very important in decision making of cataract surgery with or without endothelial keratoplasty. And in these cases, it should be differentiated from pseudogateta, which usually present in the infection or inflammatory cases where the endothelial cells get swelled. This is a case of macular dystrophy. Here you can see that many dropouts areas are present, and because of the presence of this kind of endothelial cells, now people are preferring doing PK rather than deep lamellar keratoplasty in macular dystrophy. This is a case of posterior polymorphous endothelial dystrophy. Here again we see some dropout area, and we have to correlate this finding with the slit lamp picture, and then only we can make this diagnosis. The very characteristic finding present in ICE syndrome, that is dark light reversal pattern. Normally what we see in a specular microscopy, the borders are dark and the center area looks bright. But what happens in the ICE syndrome, the borders become light in comparison to the center area, and this is called dark light reversal pattern. In any case where the specular gets some hindrance, like there is, if the cornea has any kind of opacity, haze, then we cannot have a good endothelial image, and here we cannot rely on these findings. The very important indication of specular microscopy in eye banks. So here, if you get a clear, good picture, that means that donor cornea has very good number of endothelial cells. But usually what we get in eye bank setting is specular microscopy, islands of endothelial cells, and we count those islands basically, and then machine gives the number, and it can show many pigments, stress lines, and we decide actually PK or DSEC or DMEC on the basis of endothelial count. So specular microscopy is a simple and very valuable tool for evaluation of corneal endothelium in normal and diseased eyes. But the interpretation of these specular micrographs should be in correlation with the slit lamp findings. Thank you.
So, Rakhi, do you advocate all cataract cases to be taken off for specular before surgery? Or clinical evaluation or specular biomicroscopy is good enough to supplement the informations?
It is not mandatory to do specular microscopy in all the cases, but to learn better things or to anticipate some problems, like you can advise these cases in some particular cases where you are thinking that this case may need some additional procedure, like in cases of pseudoexfoliation or chronic glaucoma cases, or if there is any history of viral keratitis, then these cases this test is mandatory. Otherwise, just for your satisfaction or your type of procedure you are planning for, then you can do this test. There is no harm in doing a specular microscope in all the cases.
I would like to do in those patients who had very hard cataract, brown cataract, and any patient who have undergone cataract surgery with one eye corneal decompensation, then other eye must be evaluated for.
In these cases, it is mandatory.
The last one, the patient with decompensated cornea in one eye, these are the patients who are very crucial.
Exactly.
So thank you, Dr. Aki, for this wonderful talk. Now I'll invite Dr. Prabhakar for delivering the talk of Dr. Nilesh Mon. Unfortunately, he couldn't make it. Dr. Prabhakar is from All India Institute of Medical Sciences, New Delhi. He has done his MD, fellowship from LVPI, and now working at AIMS Patna. Wonderful corneal surgeon. He'll be talking on insight into anterior segment OCT. This is out of turn presentation since he's also guiding two students in TOT. So he has to be there. Thank you.
Dr. Nilesh.
So very good afternoon, and thank you so much, sir, for such a wonderful introduction. So I will be presenting on behalf of Dr. Nilesh Mohan, sir. I will be talking on anterior segment OCT, and so basically we know that we have a newer, modality in our armamentarium as an anterior segment, that is the anterior segment OCT, which is of a great help, and we know that what is the main advantage of this ASOCT is that it is a non-contact procedure. So if we talk about, say, even ASOCT or an UBM can also give you much more information as the ASOCT, but the basic difference between the two is that the procedure is a non-contact procedure and it does not require a skilled operator to operate. And of course, it is giving you a higher axial resolution, and the acquisition time is also less. So it is definitely giving you more information because it's more axial resolution is there with ASOCT compared to UBM. So it's a greater tool. I'm not talking about the mechanism per se, but I will let you know. Sorry, I'm sorry. So, so what are its applications? We do anterior segment OCT in cases of corneal and ocular surface diseases, anterior segment surgery, and as well as in glaucoma. So as far as ocular surface diseases are concerned, we can map the ocular surface. We can see not just the ocular surface, but also about the corneal thickness in different diseases. We can identify the level of deposition of different, say, macular dystrophies, how deep your deposits are there, or whether it is involving the deeper layer or endothelial layer or not. It is helpful in finding Descemet's membrane detachment in patients with cataract surgery. If there is a persistent corneal edema, you are not able to see on slit lamp the extent of Descemet's membrane detachment. Anterior segment OCT is a great help to identify that and subsequent management. As far as opacities are concerned, we can actually measure what is the depth of that particular opacity, and we can manage accordingly. And we can either go ahead with simple anterior lamellar keratoplasty or whatever is needed depending upon the depth of involvement. Apart from this, as I said, if you're doing DALC, again, post-operatively, you can assess whether what is the extent of the double anterior chamber, and you can go ahead and rebubble and try to settle the double anterior chamber. Similarly, for DSEC that we do for bullous keratopathy patients, we see that how well the graft is attached to the recipient. So we can go ahead and see on ASOCT very well, though we can see it even on slit lamp. But when the cornea is very much edematous on first post-operative day, which is very crucial, because if it is detached in the first post-operative day, you can go ahead and quickly rebubble and help it reattach. As far as implantation of intrastromal ring segments is concerned, you can see very well over there that we can judge the depth at which you have implanted it. So usually we say that it is 60 to 70% depth that is preferred, and we can see it here. So it gives you a lot of information, just not helping in making a diagnosis, but also later on to follow your patients. Similarly, in various corneal ectasia disorders like pellucid marginal degeneration, or even for that matter keratoconus, you can see the extent of corneal thinning or any sort of scar, or the level of scar if it is a healed hydrops. And definitely in bacterial keratitis also, you can go ahead and do anterior segment OCT, and you can find the level at which, till which the infiltrates are reaching. Apart from that, you can also judge the areas of thinning in cases of healed keratitis. Yes, so again, these days we have shifted significantly. Previously, we used to go for, in cases of OSS, and we used to go and we used to do biopsy. But these days, with the help of anterior segment OCT, what we are doing, nowadays we have, limited ourselves, and we don't go for surgical management. Rather, what we do, we just go ahead and do an anterior segment OCT. We see the abrupt transition in the epithelial cell caliber, and this is how we make a diagnosis. So even for that matter, the impression cytology has lost its role, and largely we are making our diagnosis based on the anterior segment OCT images, and accordingly we treat, and we even follow up based on the anterior segment OCT pictures. Similarly, you can identify the level to which the foreign body has entered into the cornea, and accordingly, you can decide your plan whether you can take it or do it in the just in the OPD setting, or you want the patient to take to the OR. Intraoperative OCT, yes, that is of great help. That tells you as to how deep you are working into the cornea. So definitely, it is a great help in DALC, DSEC. You get to know on table, okay, my graft is still not attached, so I need to rebubble. And yes, anterior segment surgeries like LASIK flap, we evaluate. So again, here even in the, for that matter, in LASIK, post surgery, we can follow the patient if there is any sort of, say, infiltrate in between the flap and we're not able to make out it properly. We can go ahead and do anterior segment OCT to find the extent, and we can also, we see, apart from this, we can also see as to how, say, if you have done a case of LASIK and you want to assess how smooth is the interface. So again, this helps you to choose which one is better for you or which works better in your hand. So as far as glaucoma is concerned, yes, you can do this, use this modality in even in malignant glaucoma. You see that the central anterior chamber depth is completely obliterated, and subsequently, when after treatment, after hyalodotomy, the anterior chamber is deepened again. Apart from this, there are various features that you see, the angle structures you see the bleb morphology, and yes, and you can also do anterior segment OCT in patients where you have implanted shunt. So you can see the relation between the tube and the corneal endothelial cells, or the corneal endothelium per se. Apart from this, you can also see the patency of the shunt tubes. And these are the different quantitative parameters that are helpful in identifying as to how is your angle structures. And so obviously, gonioscopy is the gold standard, and we cannot say that anterior segment OCT is better than gonioscopy. Your clinical findings are always, or examination always takes the upper hand. However, still anterior segment OCT is a good tool to complement gonioscopy. So to conclude, a wide range of corneal and conjunctival pathologies, and it has a multiple use in corneal pathologies, conjunctival pathologies, and glaucoma. It is quick and rapid. It is a non-invasive procedure, and even it does not require a very skilled person to do it, and it can be utilized even in an immediate post-operative period. So with this, I would like to conclude. Thank you.
Thank you, Dr. Prabhakar, for wonderful talk given to you at very short notice. Thank you for your ready availability. Now I invite Dr. Mamta Singh, who is Assistant Professor at Rajkot AIMS, for delivering talk on corneal topography and clinical implication. She is again one of the leading corneal surgeon, was working with us in Bihar and now shifted to Rajkot at Rajkot AIMS.
Thank you, sir. Thank you, AIOS, for this opportunity. I will be talking about corneal topography. We all know that refractive surgery has come up in the very big way in our market, but it's very important to know when not to operate. That is where the exact catch is. And for that, we need to know the basics of topography. So topography is basically the science of describing or representing the feature of a particular surface. And mainly we have two types of topographers in the market. One that just does the surface topography. It will just talk about the surface. And next, that will talk about both anterior as well as the posterior surface. So they are mainly based on Scheimpflug camera or Scheimpflug-based devices they are. So if we talk about the placido-based system, the idea here is we will be using a series of concentric illuminating ring, and we will be reflecting it over the surface of cornea, and then we'll try to analyze the size and distortion of this ring pattern. But the limitation here is we are not looking at the posterior corneal surface. So obviously, we cannot talk about the pachymetry value here. And the second thing, at periphery or even in the center where exactly the camera reflection is, the data are not true data. They are mostly extrapolated data. So at those places, we are not actually working on true data. But if we talk about elevation-based topography, it talks about all the three coordinates, X, Y, and Z. But the problem here is if we talk about the surface topography here. And if we compare Placido versus this Samfleck devices, at least the accuracy is limited here. And that is where the concept of integrated topographer came into picture, where we do the surface analysis with the help of Placido-based devices and the posterior segment analysis, sorry, in the posterior part of the corneal analysis with the help of Samfleck camera. We had orb scan also, which works at a different principle, but mainly we are going to talk about Samfleck devices here, mainly Pentacam. So they consider nearly 25,000 true elevation point to give the actual picture of corneal surface, and even the finer movements of eye, they get negated because of presence of a second camera. And if we go through a typical topographic map, it has got two parts. One on the left side where we can see certain digits, and on the right side we can see certain color-coded maps. So if we start from the left side, from the top, it is patient information about the corneal front surface, back surface of cornea, pachymetry information, and then info about the other parameters. So starting with the patient information, we need to know when we are doing this topographic scan, what is the date of birth to compare it from the normative data, and similarly which eye is being done. Then comes the corneal front surface. Before analyzing any of the topographic map, we need to be sure about the quality of specification, whether the scan quality is okay or not. So this has to be decided. Then the Q value, basically it denotes the shape of cornea. Normally it is between 0 to 0.5, it's in minus. Then comes RH. This is horizontal radius of curvature in the central 3 millimeter of cornea and the corresponding K1. This is vertical radius of curvature and the corresponding K2 in the central 3 millimeter. This is mean and the corresponding K mean. What is the amount of astigmatism on the front surface of cornea and at what axis? What is the peripheral radius of curvature, where we are considering 9 millimeter of cornea? And what is the minimum? If suppose a particular portion of cornea is bulged, then probably the R mean would be different and our mode of action would be different in those cases. So we have to pay attention at this R minimum. All these values would be similar. They will be represented in the similar manner on the back surface of cornea also, but the difference would be the power map would be in negative. The reason being the posterior surface of cornea, because of the difference in the refractive index between cornea and the aqueous, the rays are actually getting diverged. So it will be in minus. Then comes the pachymetry map. Mainly we check the location of 3 points. One is the pachy apex, that is how much is the thickness of cornea at the corneal apex, and we take it as coordinate 0 or the point 0. And then we try to know how far is the pupillary center and how far is the thinnest location of cornea and what is the thickness at them. So mainly we are checking thickness at pachy apex, pupil center, and the thinnest location. Other parameters like chamber volume and cornea volume. Cornea volume is important in cases of keratoconus, but the exact, the cutoff has not been clearly defined for Indian population. Chamber volume is very important when it comes to phakic IOL. Keratometric power distribution, again, we check the power between value between 1.5 is lesser than 1.5 is normal. What is the angle? How much is the AC depth? And AC depth is again important for phakic IOL and pupillary diameter. Then if we shift towards the right side of the map, we have this color-coded map. And this color coding is based on Louisiana State University color coding, which talks that the cool colors, the violets and blue, they represent flatter cornea. The green and yellow, they are normal portion of cornea. And warm or hot colors, they are basically representing the steeper meridians. So if we talk about a simple, the typical representation, then we have, on the top left, we have this sagittal map. Then elevation at the front surface of cornea, elevation at the back surface of cornea, and the corneal thickness map. This sagittal map is something like we are looking at the cornea from the front, right from this axial view. So anything which is very much abnormal is going to be apparent here. So if finer details we cannot decide based on the sagittal map. If we want to read one particular point in details, then we need to take this tangential map where every individual point is considered in details. Then the corneal thickness map, as I said earlier, there would be 3 points where we normally check it: the pupil center, pachy apex, and the thinnest location, and location of one with respect to pachy apex. Then comes the corneal thickness spatial profile. Here what we do, we take the thinnest portion of cornea. Then we draw 22 concentric circles around it. We check the pachymetry, the average pachymetry on individual circle, and then we draw it from the center to the periphery. That is how the entire thing is done. The patient's value will be represented in red color. The normative value will be represented in interrupted black line. So it is important to know whether the pachymetry value is lying within the normal limit, plus whether this progression from center to periphery, this is progressing in the normal manner or not. That is also important. For example, here we have a case where although this is well within the normal limit, we can say the corneal thickness is between 400 to 600, but we can see the center cornea is almost as thick as the peripheral cornea is. So this was a simple case of corneal edema. That is the importance of the CTSP graph. Then comes the most important map, that is the elevation map. Elevation map talks about the given cornea in reference to a reference body, which is actually machine generated. Normally it is taken as sphere, but in cases of very irregular cornea, astigmatic cornea, we can choose ellipse or toric ellipsoid also. For example, if this is a cornea and this is the reference body we have, we can see that there is one point where the cornea and the reference body are they are touching each other. So this will be point 0. Any portion of cornea which is below this reference body would be demarcated as minus, and the portion which is above this reference body, that will be denoted as plus sign. That is how the things work. The most common algorithm which is used is the Bellin-Ambrosio algorithm. They take or they analyze the central 8 to 9 millimeter, and they choose best fit sphere as the reference sphere, and the scale is varying from plus 75 to minus 75. So in comparison to the reference surface, if the anterior surface of cornea is elevated less than 12 micron, or if the value is less than plus 12, this is normal. Between 12 to 15, this is suspicious, and more than 15, that is keratoconus. That was the original algorithm. Now we have this revised algorithm also, the enhanced ectasia scale. So if we talk about some normal pentacam value that we consider in usual scenario, but case to case it may vary. K reading for refractive surgery, normally we take 48. And if we have very finer blades, probably one can go for 49 also. Corneal astigmatism less than 6 diopter gives better, quality of vision also has to be maintained, because beyond that, probably the shape of cornea would also change. Thinnest location, even for PRK, better to have the lowest value of 470. Within the 4 millimeter circle, the anterior elevation should be less than 15, posterior elevation should be less than 20. If the superior is steeper than inferior, then the difference has to be less than 1.5. If the inferior is steeper than the superior, the difference has to be 2.5. And the superior-inferior packet difference should be less than 30. These are the normative value that we talk about. So if we talk about this scan, we can see here that nowhere the value is like reaching 48, 49. Anterior elevation seems to be pretty fine. Posterior elevation again less than 20, and the pachymetric value appears to be normal, and the quality of scan is obviously it is okay. So this was a normal corneal topography. Next scan, if we see it here, here we have 45.9. And here we have 44.4. So 1.5 diopter of astigmatism is there, and we can see this axis is steeper, the vertical is steeper. But elevation is normal. On the posterior surface also in the center, it is normal. And here we can see the pachymetry value is normal. So this is simple, a case of with the rule astigmatism. If we talk about this case, what we can see it here, this appears to be normal. This also appears to be normal. Nowhere it is more than plus 12. But here we can see at this particular point, this is plus 20. But if we correspond it with the pachy, we can see the pachy is normal here. So this could be an early case of ectasia. So particularly in these cases, we shouldn't exactly jump for the surgery. Probably we need to follow up these cases. This was a case where we can see everything is going wild. It's like, keratometric power is again very high, anterior and posterior elevation all very high, and we can see the pachymetry value is very less. So this was a clear-cut case of keratoconus. So with this, I would like to conclude. Thank you so much, sir. Thank you for this opportunity.
Thank you, Dr. Mamta. So any guideline about when one should order for this topography in young kids? Because these are the patient of early keratoconus.
We are seeing more number of vernal keratoconjunctivitis cases these days, and they have this tendency to, continuously rub their eyes. So if there is change in glasses, if the cylinder is more than 2.5, for me it is 2.5, but if you go theoretically more than 3 diopter of cylinder, then it's better to have a baseline packet done. It will cost probably 1,000 rupees to the patient, or 1,000 or 1,500 rupees to the patient. But once we have this baseline packy, and if there is a change of glasses, say more than zero point 0.5 or 1 diopter in say 1 year, then I would definitely like to follow up these cases with the next packy, how much there is a change. Because when we talk about early C3R, in these cases, pediatric cases, our threshold should be really lower. Because I have seen a 9-year-old kid also going for high drops. So in these cases, we really need to be on our toes. Pregnant female, C3R, these pediatric keratoconus cases, we need to go for early topography, sir. That is for sure.
And these topographers are usually coming with some other modalities of evaluation of anterior surface,
I think
like tear film and other thing.
Yes.
Is that going to add on with the information, or they are just of mathematical value?
No, so definitely anything which is going to be, give information about the surface particularly, that is going to be there. Because we all know that dry eye, in addition to any of the allergic disorders, they are like going to be the added hazard over the ocular surface. I think Aryo Patna has got one serious with dry eye module, I guess, yeah.
You want to say something, Dr. Rakhi, on what added information that those regarding the aqueous film and tear surface it is giving?
We have serious photographer, and in that machine we have non-invasive field and we can measure it easily, as well as mammography we can do. So in the patients where suppose there is a dry eye, and these dry eye patients usually sometimes it's difficult to do the Shamas test or the fever time on slit lamp. So these patients can go for non-invasive as well as the topography at the same time. And sometimes dry eye patient usually gives a very fallacious result on topography. So better to put 1 drop of lubricant and then go for it.
Even if you talk about dues too, sir, the ideal is non-invasive TBUT. That is what they talk about. So in that way, it's definitely going to help there.
The Cirrus is helping because it has got both the things, the Placido disc as well as the simpler camera.
Integrated, yes,
That is the advantage point here. So it can very well map the anterior surface, the tear film, mammography, even the pupillography it can measure. And even the lens power kind of thing, all can be done with the same machine.
The same system is there with the Galilei also, sir.
Yeah.
That is also
Yeah,
wonderful.
Galilei has both.
Both. Yeah. Thank you so much, sir.
Thank you, Dr. Mamta. Now I invite Dr. Subhas Prasad, one of the leading surgeon from eastern part of India, well known all over India. Started with vitreoretina at RP Center, then turned into a prolific phaco-refractive surgeon, and now back to retina, retinotomy by OCT and OCTA. So welcome again, sir, back to VR days.
Let me tell you that it is not the domain of retina specialist. Everyone should know and should be doing this. So thank you, Dr. Vibhuti, for including me in this course, and to AIS also. So I would be briefly talking on, because it's 8 or 10 minutes time, very too less to describe anything about OCT and OCTA. We all know that OCT is one of the most commonly done investigative modalities in ophthalmology nowadays, be it posterior segment or anterior segment, and because it is non-invasive, non-contact, real-time, quick and reproducible, so it is being widely used, and any practitioner who is doing ophthalmology must have OCT in their kitty. So it's all because it takes cross-section picture of the retina. So what are the optical principle OCT? In briefly, it is analogous to ultrasound, but here in place of sound wave, we use the infrared, near infrared light, which get back scattered from the different layers of the retina, and depending upon the time delay and the intensity, it produces image. Since the light travels so fast that we cannot measure it, so that's why we use a reference arm here. Whereas in OCT, whereas in ultrasound, we don't need any reference arm. This is the basic principle. I won't go into that much detail. The first one was the time domain, but it used to take a lot of time, and the quality of the image was not very good. So SDOCT or spectral domain OCT cam, it used wide beam of the light. Because of that, the image quality improved. And if you come to the evolution of the OCT, started with the time domain, then the spectacle domain, then the landmark change was the introduction of the stepped source OCT, where a tunable light can be used, the laser can be used that even image the choroidal part of the retina and choroidal part very well. So that has been very useful. But what was lacking in the OCT was that the ability to delineate the vasculature of the choroid and the retina. So that's why it gave rise to the thought of introducing new modalities, that is OCTA or OCTA in short, OCT angiography. So this is the picture, just say that time domain and the spectral domain. The spectral domain is always better in the form of that it has a better resolution, better because of the high speed of the ultrasound, high speed of the A scans as compared to the time domain. And comparing with the swept source even give better quality of image. It can penetrate further into the choroid because it has much more number of A scans per seconds. So we can assess the retina qualitatively and quantitatively by using the OCT. It gives us the information about morphological changes, reflectivity of the structures, shadowing, structural changes like segmentation, alteration, loss of structure. And we can do quantitative assessment like volumes, the thickness, and all the other things. The commonly used protocols for scanning the macula is three-dimensional scan, which consists of the line in a rectangular box. Numbers of lines can be sent, and that actually gives rise to the picture through which we can assess the thickness and volume of the macula. Raster scan is a series of parallel line scans, and radial scan consists of so many lines, say around 12 lines that can cross through the fovea, and it gives the relationship of the changes as compared to the fovea. So this is the actual picture if we do SD-OCT. So here one has to know that which are the structure which are more hyperreflective or hyporeflective. So any layer which has got horizontal alignment of the fibers, like say plexiform layers or the ganglia or the internal limiting membrane, they are going to be hyperreflective in the normal scan. Whereas anything which is not arranged like that, like ganglion cell layer, internal nuclear layer, or outer nuclear layer, they are going to be hyporeflective. Retinal vessels can appear as circular hyperreflective structures. So outer retinal layers are most of them are hyperreflective. The external limiting membrane, ellipsoid joint, interdigitation zone, and the RP Brooks membrane all are hyperreflective. So anything which is abnormal should alert us. So what are the things which can cause abnormal reflectivity? That like reduced reflectivity is in any fluid which is there in the retina, like retinal edema, subretinal fluid, sub-RP fluid, like in AMD, neovascular AMD. Increased reflectivity like in epiretinal membrane, CNVM, RPE hyperplasia, and if there is hyperreflectivity of choroid, which can be seen through the RPE atrophy. So coming to something about OCTA or OCT angiography, it is again just you can say that one step ahead of the OCT, normal OCT, and this is the extension of OCT that uses the motion contrast to visualize the vessels. It is based on the concept that in a static eye, only moving structure is blood flowing through the vessels. So sequential B scans are taken at same cross sections thrice, and if the subsequent scans are showing some changes, that means there is blood RBC flowing through that, and based on multiple analysis, it gives the structures to it gives the information about the blood vessels. It is again non-invasive and does not require any injection. So this is the principle of OCT angiography. No need to go into that detail because of paucity of time. Earlier we used to do a lot of fluorescein angiography, and with the introduction of the OCTA, many times we don't even need doing the fluorescein angiography nowadays. Because of the various side effects associated with the fluorescent dye, as well as it is invasive procedures. So and that cannot be repeated so oftenly. In serial follow-up, we can't inject the particularly those diabetic patients. So the disadvantage is that this is a new technology, and there is more chances of artifact also. And this OCT angiography actually cuts the layer into 4 parts in such a way that it segments the retina and choroid so that we can see the changes in particular layer. Like superficial capillary plexus, deep capillary plexus, outer retinal layer, or choriocapillaries. With fluorescein angiography, we are very much able to do the angiography of the superficial capillary plexus. But what is most useful here is deep capillary plexus, which cannot be seen with a normal fluorescein angiography. And outer retinal layer, anything which is seen abnormal in outer retinal layer generally doesn't have any blood vessels. So any abnormality here alert us, probably there is a choroidal neovascular membrane. So this is how it looks like, the superficial plexus, deep plexus, deep retinal layer, and the choroid layer. Based on the ability to image flow in the retina and choroidal vasculature, three patterns can be seen. The abnormal flow, that will depict there is new vessels. Absence of flow will guide us that the patient, this area has CNP, and abnormality in vessel geometry also, like aneurysm, dilated vessels. So one has to concentrate on retinal vascular disorders like superficial and deep slash for any condition which causes problem in the retina. And for CNVM, one has to concentrate on avascular outer retinal choroidal complex lab, and one has to be alert about the artifacts also. So how OCT is helpful in retinal disorders? It can depict very well pre-retinal, intraretinal, and subretinal diseases of the eye. In diabetic retinopathy, this is one of the most useful tool which is used in diabetic retinopathy. Why OCT? It can detect macular edema, it can classify macular edema, it can predict the outcome of treatment of the diabetic macular edema also. So OCT-based class, it was possible to do the classification of the diabetic maculopathy because of the OCT only, like spongy retina or CME or traction. Sponge-like thickening is the most common presentation, and it responds to treatment very well also. We can see cystoid spaces in the diabetic maculopathy. Serous detachment are also not very uncommon in diabetic macular edema, and any traction. So this is very important. It was not possible to see this with the normal angiographic picture, and many times with the patients not responding, not recovering with the anti-VEGF, this OCT comes as a help to show that there is traction. Because of that reason, patient is not improving. So it's very helpful tool here. There are certain biomarkers which tells us which patient is going to improve better, which is not going to improve. And where is the role of OCTA in diabetic retinopathy? Not very much. But in mild NPDR, you can pick up the changes which are not even seen in the fluorescein angiography. How? It can show you the distorted or enlarged FSZ, and it will guide you that this patient needs probably more frequent follow-up and kind of thing. So this is my mild NPDR cases. You can see there is enlarged FSZ enlarged, and in sarcinate retina, you can see even the microaneurysm here with the OCTA. CNP area very well delineated. IRMA. This is the new vessels. You can see the NBD. Just to tell you that it doesn't need OCTA to confirm or for NBD or anything, but it helps us in documentation also. Coming to the another very important topic, disease of the retina and choroid, that is CNVM, which is again the OCTA is very helpful. Not only OCT, but the OCTA is also very helpful. Because of the OCT, we are able to classify this neovascular membrane type 1, type 2, type 3. Type 1 is basically sub-RP, which is again not very much visible with the normal fluorescein angiography. You can't go beyond the RP to see it very well. So here the OCT A is very helpful. Just see here some OCT picture and the patient improved with the injections. This is OCTA picture, CNVM here. With the anti-VEGF, this size of the CNVM has actually decreased in size. So this helps in evaluating the progression of the disease. This is another patient, CNVM here. OCT angiography very well pick up the lesion. So there is another condition of the retina like CRVO. We all are aware of that. You will get macular edema with BRVO also. In CSR, earlier we used to do fluorescein angiography, but we know that most of the time it is not needed for diagnosis of that CSR. Just to do only in those patients where it is not responding, and if you want to do laser, in that cases, probably you need fluorescein angiography. But just to document and to convince the patient, OCT has come as a very good tool. And vitreomacular interface, again, OCT is very much helpful. Macular hole is again one of the disease of the macula which really needs OCT for classifying it and for seeing the result of the surgery. I won't go into that much detail. OCT after surgery, you can see that the hole has closed. I will, there. So just to summarize, OCT is indispensable for retinal disorder, particularly macular pathology. And OCT angiography enables us to visualize retinal and choroidal vasculature, even in those situations where fluorescein angiography is not possible to give us the detail. And the need of dye angiography has decreased to a large extent, being simply because it is non-invasive, it's repetitive, and very easy to use. At this point of time, I just want to acknowledge Dr. Deepak Agrawal for giving some of the slides. Thank you.
Thank you, sir. Sir, just want to know whether in coming days this angiography is going to be replaced by OCT, or angiography is going to stay as one of the armamentarium.
Fluorescein angiography has its own role because it doesn't give the type of leakage just so that the vessels, there is some abnormality. Even in CNVM, sometimes some vessel may not leak once you give the injection. But here in the OCTA, it will show that some vessels are there. Though it may be shrunken, it may be less. So that there is always a role of fluorescein angiography just to see the dynamics of the leakage of the dye.
So can we in future see a machine incorporating both part, angiography and OCTA?
Some machines are there.
Some machines are there.
Yeah, that Mirante, it has got wide field, ultra wide field view. You can do fluorescein angiography also. You can do Opta also.
Okay, so that is going to give lot of
even the ICG also there.
ICG also. Thank you, sir.
Thank you.
So now I invite Dr. Rashmi, who is associate professor at AIMS Devgar, for her talk on disc dissection by OCT, coming to the glaucoma part. This OCT is again giving lot of information regarding the disc analysis, and when it correlates well with your clinical finding, it enhances the chances and enhances the chances of correct diagnosis. So Dr. Rashmi, please.
Thank you, sir, for giving me this opportunity. So my topic is dissection by OCT. So one declaration I have to make. In my presentation, I have used brand name of some OCTs, but मुझे किसी ने कुछ दिया नहीं है. I have no financial interest at all. So when we talk of disc evaluation, what are the diseases which come into our mind? Primarily glaucoma, it's an optic nerve head neuropathy, and some diseases which are primarily linked to optic nerve head, that is ischemic or demyelinating or inflammatory diseases, or secondly affecting the optic nerve head, that is disc edema. So disc imaging, as far as investigating modality, has not been incorporated per se in neuro-ophthalmic workup as a primary modality, but it has been able to make its role, create its space as far as the management and diagnosis of glaucoma is concerned. So I will be talking about basically use of OCT in glaucoma. So for disc imaging, we have a number of tools, but the most common tool which is being used worldwide is optical coherence tomography. Optical coherence tomography, as has been explained by my previous speaker, is a non-invasive in vivo cross-sectional imaging technology and is analog of ultrasound imaging. It generates high resolution cross-sectional 2D and now even 3D images for internal tissue microstructures, and has seen evolution since its inception in 1991 to its introduction in 1996 to the current state. And the basic evolution is in speed scan, which has made improvement in resolution, better penetration, repeatability and reproducibility of the data, and even the area of scan. And even the spectral domain OCT has undergone many modifications like adaptive optics or incorporation of visible light optics. And the just previous speaker has told about OCT angiography, which is now delineating the vascular pathologies as well. So spectral domain instruments are available commercially. You have heard Cirrus or Spectralis, RTView from multiple manufacturers. Resolution, scan, acquisition rate, and measurement across these devices are generally not interchangeable, but their ability to detect glaucoma is very similar. So OCT scan from one instrument needs to be compared with the same instrument as well. Apples cannot be compared with oranges. Okay. So as far as glaucoma continuum is concerned, OCT holds its place even before we get the visual field changes. That is pre-perimetric glaucoma. What does this OCT do? It objectively measures the thickness of each retinal layer and does a topographical analysis. And it basically measures the neural structures, be it retinal nerve fiber layer, optic nerve head, or ganglion cell complex. I will be dealing with the three parameters one by one. Coming to the first one, retinal nerve fiber layer thickness parameter. It is generally done by using a 3.4 millimeter circular scan centered on the optic disc, which takes subsequent scans with different speeds depending upon the machine. And this is the most reproducible parameter. It gives a deviation map, it gives a thickness map. But the point to be noted is color coding. In thickness map, the red is thicker nerve fiber. But in deviation map, the red means it is significantly lower than as compared to the normative database. So while evaluating the thickness as well as deviation map, this color coding needs to be kept in mind. Second is Tisnit graph. That is the scanning done from temporal to the, and again reaching to the temporal when it is plotted in a graph. And the thickness parameters are even represented by quadrants, clock hours, or sectoral graph. So all these parameters, sub-parameters rather, in RNFL analysis needs to be taken care of. How do we use them? So this is a case, 40-year-old male with pre-perimetric glaucoma. You can see inferior temporal nerve fiber defect in red flea light corresponding well with thickness map, with deviation map, and also with the Tisnit graph and the sectoral. So it's all good. All are collaborating. So initially there was no different change in the visual field, and gradually visual field difference appeared. So what about this case? It's a pre-perimetric glaucoma patient. There is change in the optic nerve inferotemporal part, but that is not been depicted in the sectoral as well as clock hours map. But this is very well depicted in deviation as well as thickness map and is corroborating with the Tisnit graph. So we have to correlate the subparameters as well. Now coming to the macular parameters, spectral domain OCT uses 6 into 6 millimeter macular cube, while the swept source OCT uses a wider field, that is 12 into 9 millimeter scan. And the measurement given is in two forms, GCC, ganglion cell complex, or GCA or GCIPL. Different machines have different inbuilt formulas for calculating them. Now, minimum GCIPL is the best parameter for discriminating early glaucoma, while inferotemporal GCIPL is best parameter for myopic pre-perimetric glaucoma for healthy myopic eyes. As said earlier, swept source OCT with a larger macular scan than the spectral domain has better diagnostic performance because we get an overview what is happening in the RNFL, neuroretinal rim, as well as the ganglion cell. As you can see in this graph, 48-year female with pre-perimetric glaucoma has a corresponding lesions in the quadrant map as well as in the deviation map. That was not depicted earlier in the visual field, but gradually she developed this defect after 1 year. So coming to the optic nerve head parameters, it is basically the quantitative analysis of the neuroretinal rim, where we measure rim area, vertical rim thickness, vertical CD ratio. But due to the variable orientation of the rim tissue to optic nerve head, newer parameters like Bruch's membrane opening, minimal rim width, and 3D and RT has been introduced in SDOCT for better ability to detect this glaucoma. So what is this? Why these algorithms are there in this machine? Basically, how do we get the size of the disc and how do we calculate the size of the cup? So taking the Bruch's membrane opening as one point for the optic disc measurement, and then taking it as a reference plane. Different machines have different cutoff levels above which the cup values are calculated. Cirrus has 200 microns above the RP, RT has 150 micron, and 3D OCT has 120 microns. But there are some situations when this disc margin is not very well delineated, like high myopia, then the Cirrus or spectralis OCT calculates the BMO MRW, that is minimum distance between the BMO and ILM. And this is said to be reference plane independent to overcome the structural abnormalities in certain diseases. This is the cross-sectional as well as longitudinal diagram, how this BMO MRW is calculated. This is the Bruch's membrane opening, and this is the minimum distance from the eye limb, and this is the minimum rim width. This is being shown in the cross-sectional image as well. So again, a left eye of a 43-year-old female with pre-perimetric glaucoma. Here, both the Tisnett graph of BMO, MRW as well as RNFL thickness are correlating. So there is no problem in this case. But what about this? This is abnormally looking disc, but there is no RNFL changes in clinical examination as well as red-free light, but you are getting some red areas in deviation map as well as Tisnett graph, quadrant map, but when you do an BMO MRW, this patient is absolutely within normal limit. So these are the situations when these parameters come to our rescue. Otherwise, this patient would have been undergone management for glaucoma for rest of his life. So NRR parameters can be complementary to RNFL or macular JCIPL in detecting early glaucomatous change with improved specificity. Again, a 40-year-old male with pre-perimetric glaucoma. What do you see here? You can see changes in deviation map, thickness map, but the quadrant maps are and the sectoral maps are absolutely normal, but you are getting changes in RNFL Tisnett graph as well as neuroretinal rim thickness graph. So again, this is corroborating with the clinical picture. So this patient is having glaucoma. Other areas what we have to look for in the scan is patient details, because after all, the patient details needs to be compared with the normative database. So so age and ethnicity as well as refractive status of patient is important. Image quality, every machine has different signal strength, and for a spectral domain OCT, a signal strength of less than 6, the image should be discarded. After 10, the image quality needs to be more than 6. And spectralis, every machine has its own inbuilt or fed data for image quality, and that should be taken care of. Then another point, tomographic landmarks needs to be taken care whether the Brooks membrane opening has been rightly demarcated or not. Otherwise, the whole of the calculation will go haywire. And this is the disc and NFL parameters, which has been shown in this graph. Every machine has its own database with which the data of the patient is compared and is given a red or the green or the yellow color depending upon the amount of deviation from the normative database. Coming to the macular scan, again the patient data, signal strength, thickness map, deviation map, macular parameters and horizontal B scan. All parameters needs to be rechecked while interpreting the map. There is another software in these machines which is called GPA. As we have in Humphrey's visual field, there is a guided progression analysis for individual parameters as well as that can be event-based or trend-based, taking into account the age accountability of the loss of RNFL or the ganglion cell. This is a map which is denoting the average RNFL thickness, superior RNFL loss, or the inferior RNFL loss in a decreasing trend, and different color coding denoting progression. Again, this nerve fiber layer is when compared with the macular ganglion cell. This is corroborating with the Humphrey's visual field analyzer as well. Similar is the analysis with Brooks membrane minimal rim width, and this is also showing progression with quantitative measurement, whether the deviation is significant or not. New advancement in the imaging modalities of the disc is imaging of the lamina cribrosa with the invent of swept source OCT, which is now known to have potential to serve as biomarkers for the glaucoma progression. And the main structures which we look for in cases of glaucoma is the microstructures of the curvature of the lamina cribrosa as well as the thickness. All the three parameters are known to have differences as compared to the normal patients in the lamina cribrosa, and these are used as comparison tools for the progression of the glaucoma. Functional OCT, as has been described by the sir, is done by OCT angiography, and that depicts the vascular dysfunction in the optic nerve head, and it may contribute to the development and progression of glaucoma. And this is basically useful when we have inconclusive investigation reports from OCT or other things in cases of glaucoma, when the structure of the optic nerve is not so well delineated to depict a real picture when these investigations come into our rescue. As you can see, there is inferior nerve fiber layer defect, which is depicted by decrease in vascular density in this place, and this is corroborating the visual field defects. And in this case, where the situation was very dicey, it looks there is segmentation error, which is not reliable, but in OCT angiography, there is decrease in vascular density, so there is definitive glaucoma in this patient. Again, when we use a machine, we have to be aware of the limitations. There is a limitation called floor effect, because in advanced glaucoma, there is a point after which no further structural damage can be depicted. And we have to distinguish glaucoma from red disease, that is false positive, and green disease, that is false negative. And the main source of errors can be because of OCT mistakenly takes an area as abnormal, or when we ignore the sensitivity specificity of the OCT. And the main problem is the normative database included in the OCT do not include extremes of age, has no consideration of axial length, has nothing to do with extremes of refractive errors, and there is no correction factor for that. So these patients need special consideration. There are certain artifacts like motion artifacts, as can be depicted by wavy lines in the scans, and these are generally, to take care of these, high scan OCTs are developed, and there are techniques to track the eyes, but still they exist. Blink artifacts, when these data needs to be discarded, and you have to go for repeat testing. Media opacity, as you can see, vitreous opacity can get incorporated in the measurements when the whole of the calculations is fallacious. Myopia is special situation which has ocular magnification effects, and there can be true retinal thinning as well. So these patients need special care while interpreting these reports. Vitreoretinal interface problem like VMT can cause false positive green disease. This can miss focal changes because of retinal thinning. And patient-related factors again include some retinal edema or optic nerve head abnormalities. There can be instrument-related factors like poor image quality, poor OCT device performance, inaccurate optic disc delineation as seen in this picture. Or there can be segmentation error when the OCT machine was not able to identify the each structure properly. There can be operator-related artifacts when the patient data was not fed properly, OCT lens was not cleared, OCT scan circle was not properly placed as you can see in left eye of this place, and when the scan was repeated, the scan was absolutely normal. An incorrect axial alignment of the OCT image, which results when the area of focus is not within the frame. The patient head or chin rest is not properly placed. So these minute points needs to be taken care of while interpreting the reports. So in conclusion, I could say OCT for optic disc analysis remains a dynamic and evolving imaging modality with better introduction of software algorithms, and using all structural parameters in combination with one another is most effective. And clinicians should be aware of OCT limitations and possible scan artifacts, and clinical decisions should not be driven by OCT results alone. Thank you so much.
Thank you, Dr. Rasmi. That was very informative talk on OCT use of OCT in glaucoma. Just wanted to say that if there are some patient where it is not possible to do perimetry, then in those situations, would you advise that glaucoma treatment can be just started on the basis of OCT only?
It's better to have something than nothing. It's better to try to identify by the help of OCT as well, and not depending on the visual fields only.
So thank you. Let us see what Dr. Vibhuti has to say about perimetry. Now it's time to introduce the chief instructor, Dr. Vibhuti Prasanna Sinha, Professor Vibhuti Prasanna Sinha. He is the chief of the RIO Patna, and one of the best speaker we have in our Bihar, one of the very good administrator and very knowledgeable person. So welcome, Dr. Vibhuti.
Sir, regarding your last question, when visual field estimation is not possible, there should be a clinical correlation between your OCT finding and your disc finding. Then only one should start with the treatment. So I'll be talking on interpretation of automated perimetry. Because of paucity of time, I'll be skipping with a few slides. So these are the utilities: glaucoma, neurological disorders, retinal disease, visual disability. Out of these 4 The glaucoma, neurological disorders, and the visual disability are the main armamentarium which are being utilized for perimetry. The automated perimetry is one which is used nowadays because of a standardized way, accurate and reproducible results, and because of the less variability. We know the static perimetry is more important since it determines the retinal sensitivity in the visual field at different foci. We also know that the fovea has got the highest sensitivity, that is around 30 to 34 decibel. That means it can detect the dimmest possible light. The threshold is one terminology which means that the stimulus should be picked up at least 50% of the time, then it is termed as a threshold value. The decibel is the retinal sensitivity, whereas apostolib is basically the light intensity. The thresholding is usually done by two strategies, by 4 dB decibel double bracketing strategies, where the intensity of light is decreased by 4 decibels and increased by 2 decibels in a step ladder pattern, and to identify the threshold value. And fastpack is where we reduce it by twice by 3 decibels to identify the threshold value. Now, the threshold value of one point can be determined or can be rely upon because of the size of the intensity, size of the stimulus, that is usually type 3, is the 3 luminous intensity, the background illumination, which is around 31.5, which was also present in Goldman as well as Humphrey, or in the octopus, the color and the duration of the light presented to the patient. Then there are age factors, size of the pupil, refractive status of the eye, attention of the patient, and fluctuation. These are important factors that can determine the thresholding. There are various ways, qualitative and quantitative. Qualitative means supra-thresholding. That means you are presenting to the patient a age match control value which is more than the threshold value of that age match, and that identifies basically is a used usually for the neurological field, and it's a kind of a screening test. Whereas the quantitative, we actually identify the threshold value at different focus. These are some of the test pattern, that is 30-2, 24-2, 10-2. And now these are the test locations. In 30-2, usually we do 76-point testing. In 24-2, we do 54-point testing, and 10-2, we do 68-point, because the macular ganglion cells are the maximum represented at the cortical level. Now the newer pattern, that is 24-2, where 10 added points in asymmetrical pattern has been added into 24-2 program, and which gives added information about the central changes occurring to the patient. Now coming to the parts of Humphrey, this is the printout. So for convenience, I personally bifurcate it into 4 parts. Part A, B, C, and D. So see, part A has got all the information regarding the patient and the reliability indexes. Type B part has got the actual threshold value and the grayscale type. The part C has got the total deviation and the pattern deviation plot, and the part T is the statistical analysis of the printout. So let's go one by one. The part 1, the stimulus size will be there, background will be there, the test strategy has to be seen, the refractive status has to be seen, and then the reliability index. Please make sure that your macular foveal threshold matches with your visual acuity of the patient. Coming to the reliability index, there are false loss, false fixation loss, false positive, and false negative. The fixation loss is once the patient, if the patient is detecting the stimulus presented at the blind spot. The false, if it is more than 20%, the flag is on. The positive, false positive means the patient has presented or pressed the buzzer even at the sound or before the light is presented to the patient. If it is more than 15%, the test is flagged off as an unreliable play test. Then the false negative is When the patient has estimated number of the time expressed as a percentage, the response button is not pressed when the stimulus 9 decibel brighter is presented to the patient. And if it is more than 20%, then again it is flagged. If there is high false positive, there will be white scotoma. If there is high false negative, the patient with pattern will present with a clover leaf pattern, and these are two specific type of pattern which need to be identified before you get into the further details of the patient data. Now, foveal sensitivity is very important. In individual sensitivity has to be seen. Then gray scale has to be seen. The total deviation and the pattern deviation. The total deviation is regarding the average deviation from the normal age, normal threshold value, and the pattern deviation is when you flatten the curve, you take out the general depression in the curve and then point out where the foci of the depressions are there. So this pattern deviation is of more important than the total deviation. Then coming to the mean deviation and the pattern deviation, mean deviation is basically derived from the total deviation plot and indicate overall depression of the patient hill of the vision. So even with a cataract, even with all other media opacities, the mean deviation is going to go down. In case of PSD is also derived from the total deviation, but it actually denotes what is happening at a particular focus, and that tells how the numbers are different from each other. So it is more specific for the test. SF and the CPSD are now not available in newer machines. Then the glaucoma hemifield, it will flag you, it tests 5 points in the upper field and the 5 points similar symmetrical fields in the lower field, and then it gives you information in term of outside normal limit, borderline, abnormally low sensitivity and abnormally high sensitivity, which will give you information whether there is asymmetry present or not. You know that the glaucoma damage is asymmetrical. So, and then the gaze stacking, remember the upper movements of upper spikes are basically of saccades and the lower spikes are basically of blinks. If there is jumbling of these blinks or the saccades, that means the patient reliability is poor on the gaze stacking, and that need to be taken care of in the further field evaluation. Now the criteria of diagnosis: 3 non-edge point present depressed to more than 5% and at least 1 point by less than 0.5%, 1% in the cluster area, PSD depressed by 5% and GST outside normal limits. So one has to remember whether the field is asymmetrical or not, whether the cluster of the defects are present outside the border. So the peripheral areas has to be discarded in cases of 30-2, but in 24-2 one can consider that. Then one has to remember whether the defect is progressing or not, and the progression is what? Progression means whether the progression is in the size, whether the progression is in the depth. So there are various pattern. One is basically when you do a glaucoma overview program, if you have multiple tests, just place it before yourself and see what is happening to the total deviation and the pattern deviation plot. It is going to give you information, or GPA or VFI is going to give you information, but that requires multiple tests on same machine. Then only the machine can basically detect what is happening to the patient visual field. And also the VFI plot gives you information about and comparison with the normal age match control and give you information. It also flags off and give you information in form of single solid dot that indicates point not changing a significant amount. A small open triangle, that means the test is expected to be present in stable glaucoma patient. P value is less than 0.05%. A half-filled triangle means half-filled triangle is indicates significant deterioration at that point in 2 consecutive tests, and a solid triangle means in 3 consecutive tests. That means that this is pathological and the patient is progressing. So at the end, I want to say that Humphrey field analysis or the perimetry is one of the mainstay of evaluation in case not only of glaucoma but also in cases of neurological field. And for the disability purposes, a continuous and a repetitive examination is required to first to get a reliable visual field initially, and then repeated tests are required to identify actually what is happening at the micro level. Thank you very much for your patient hearing.
For neurological, what are the subtle early changes which can be useful in
I think
perimetry?
there is one criteria, RP Mills criteria is there, where one has to see the vertical line. We know that the glaucoma respects the horizontal meridian, whereas neurological fields respects the vertical meridian. So you need to compare 2 or 3 the corresponding points on each side of the line, and whether there is change in the luminosity, whether the intensity or sensitivity of those 2 points. And then the next step is to find out what has happened to the next one line into that. And if there is definitive change and there is asymmetry, it goes more in favor of a neurological field. So that is more important. And more so, one should go for 120-degree rather than 30-2. It is a kind of a screening program, give you a good kind of information in neurological fields.
There are some new machines we have seen in somebody purchasing a small that can be used as a spectacle kind of thing. So, do you have any idea how these machines are comparing with the standard perimetry machines?
There are few papers which are giving information that the comparison is good, but personally I have not used these machines. Basically give you informations. They are very patient friendly. One, they can be utilized even in the OPD. They don't require a lot of space or the dark room to actually perform. And personally, I think that that can be utilized for screening purpose rather than for the diagnostic purpose or for assessing the actual progression. So before you move to diagnose patient, if we have to do the screening of patient in a busy OPD, these machines should be utilized or could be utilized. But once the patient has been diagnosed as a case of glaucoma, the perimetry should be performed on the gold standard, that is Humphrey field analysis, and so that actual findings are perceived, and then the field estimation can further be done to assess the progression in future.
For any patient who are suspicious of glaucoma, how many field you think should be taken before completing coming to the conclusion that this field is reliable? Now we can follow.
Basically, sometimes even the patient, those who are intelligent patient, they can perform even in the first test itself. But usually 2 to 3 tests are required, and the reliability parameter is one important thing what one should keep in mind. If the reliability parameter is good and the patient test is absolutely normal, then this patient can be followed up later on for like if the patient is termed as a glaucoma suspect because of the disc changes, and that's why the patient has been taken, but the visual field turned out to be a very normal with a good reliability, this patient can easily be called after 6 months for repeat test. But you have to keep on performing these tests at least 4 to 5 times in first 2 years to see what is happening at the micro level. So this is how I personally move. If the patient test is not very reliable, then naturally we have to perform these tests at least 2 or 3 times to take out a good printout. And more so when we are also seeing the progression after treatment. Once you have done some kind of surgery, then you have to create another baseline to see what is happening further into the patient treatment protocol.
So the baseline perimetry keeps on changing depending upon the stage of the disease.
Exactly.
So any other question from the audience? Yeah.
MRF tablet-based perimetry in our department, and that was basically used in the COVID times when you didn't want to put the patient in a dome-chim perimeter. So that's iPad-based, and it's fast. It doesn't pick up the early fields, but it doesn't miss out, in the moderate fields, and it collaborates with the automated perimetry that we have. So
exactly. These are the tests which can be used for screening as a screening tool in the OPD, where because in glaucoma, we require some kind of tool which can screen masses. At the end of the day, you can't perform Humphrey in all the patient or octopus in all the patients. So you require a test which is fast, which can at least detect some true positive patients, and so there these machines fills the gap.
Above all, what is more important is clinical evaluation of the disc, the nerve fiber layers, and other things. Because many times the field comes out to be not as in the accordance with the clinical finding. So in that situation, one has to repeat the field again and then see that which.
Dr. Mamta is doing one paper on research on one field that is for driving license part.
Yes, sir. We
So
have this latest.
tell me something about
Yes,
it.
we have this latest machine by Zeiss, which has Esterman component also. Esterman actually is the most widely accepted test for driving license in Western world, at least. We do not right now. We do not have any, criteria when it comes to giving the driving license that we need to go for perimetry. So what we are planning to do, we are taking the patients and we are performing Esterman to the so-called normal license holding Indian population actively involved in driving, and then we are just going ahead with the study. Let us see how and when it happens.
So basically in India we don't require field analysis for driving license,
yeah.
because although that is very important part. So that test is kind of supra threshold test. Okay. So at the end, I want to thank Dr. Subhash.
Thank you so much, Dr. Vibhuti, for such a wonderful talk and inviting so many question answers. So thank you again. So we can have photographs.